Hello, hi everybody.
Hello.
Chair Ku, I believe we are live.
Okay, thank you so much. Good evening. It is Tuesday, March 9th, 2021. This is a regular meeting of the Policy and Services Committee. Will the clerk please take roll? Thank you.
Chair Ku,
Here.
Councilmember Stone,
Here.
Councilmember Tanaka,
Here.
3 present.
Thank you so much. We're going to start tonight with oral communications from members of the public on items that are not on the agenda. Ms. Palm, could you help me with that, or Ms. Kang?
Yes. If there are any members of the public who would like to speak in an item not on the agenda, if you could please raise your hand in the Zoom application. Chair Ku, at this time, it looks like we have no oral commenters.
Okay, very good. I just want to make an announcement that we're going to have an agenda change. We're going to move item number 3, which is information update, summary of recent race and equity work since November, including update on records management system, contract for police data collection to be before item number 2. So we will continue now with starting with item number 1, which is an update from Santa Clara County Department of Behavioral Health in relation to the Santa Clara County Mental Health Emergency Response Initiatives, including Psychiatric Emergency Response Team, Mobile Community Response Team, and the Community Mobile Response Program. Thank you for being here tonight.
Thank you. I will be starting things off, but I want to check in with all of you if you can see my screen.
Yes.
Yeah. Let me see. So good evening, council members and everyone here on Zoom. We're going to be providing a quick overview. Well, maybe not quick, but hopefully detailed enough so that you all know the current status of all our mobile crisis programs. And then at the very end, we will open it up for Q&A. I'm Jan Morrell. I'm a Program Manager 3, overseeing systems initiatives, planning and communication for the County of Santa Clara Behavioral Health Services Department. I have here with me who's going to be presenting to Margaret Overlord, our older adult system of care director. And we also have Sherry Terrell, our behavioral health services director. So when you think about the county's behavioral health programs, I'd like for all of you to, if you need to take anything away from the program, just look at this particular illustration. It showcases our continuum of care as it relates to behavioral health programming. At the very top, which you may be all familiar with, is our PERT. That's activated through 911 calls. It's the most intense level. We have a behavioral health clinician paired with a law enforcement officer. Currently, we have a team with the County Sheriff's Office, and currently there's a recruitment effort to have one with Palo Alto. The second one that you see here is a mobile crisis response team, Mcrt, and that's activated by calling the Behavioral Health County Call Center, and they are a team comprised of behavioral health clinicians, licensed waiver clinicians, and law enforcement. And it's been implemented since 2018, and it provides an intermediate level of care. The third one that you see here is the newest one, and it's currently going through the local approval process. It's currently being called our Community Mobile Response Program. In this particular program, which I'll be describing later, we'll be utilizing a model similar to the Cahoots model, where we're going to be utilizing a community-based approach. But I'm going to go ahead and turn it over to Margaret Overlord, who will be going through PERT and MCRT.
Thank you, Jan.
You're
Well, good
welcome.
evening, everyone. As Jan said, my name is Margaret Obalor, and I will be talking about the PERT team as well as the Mobile Crisis Response team. So our PERT team is a county-wide real-time response program. What that means is we respond immediately to any 911 call. And our clinicians partner with the law enforcement officers. And when you see the word active, meaning these are active duty law enforcement officers. And I'll tell you the reason why we're using the word active here. And so we arrive at the scene of the emergency and try to help to de-escalate the crisis situation. So the conditions in which the PERT team would get called was usually as a result of a 5150 requirement or criteria, which is really a danger to self, danger to others, or experiencing grave disability. It could be threatening self-harm or threatening harm to somebody else. Next slide, please. So the PERT team has a peer support element in it, which is slightly different from our mobile crisis response. And so the team has a peer person attached to the team, and that person's role is really to bridge the gap between the consumer who we're serving at that particular time and the family members, right? So they help to follow up with the individual and also help to provide other forms of linkage and outreach to the individual to assist them with continuing to receive the behavioral health support that they may need after the encounter or the crisis situation. The peer support workers are culturally competent. They have various we have various languages. They also have lived experience, which is one of the reasons why we have brought them on. And they have the capability to really engage with clients and also with services at the same time. Next slide, please. So usually the PERT team would respond so as Jan had mentioned in the very first slide, the PERT team works very collaboratively with the mobile crisis response team. And so for instance, if the PERT team is responding to a crisis situation at this particular time, and they are unable to assist or respond to another call, the mobile crisis team clinician could be asked to assist. And so that clinician will go out in the community to continue to provide the crisis response that is needed. So we work hand in hand. Next slide, please. So that's a little brief about the Psychiatric Emergency Response Team. It's a team that works very collaboratively and in conjunction with a law enforcement officer. The Mobile Crisis Response Team is slightly different in terms of the work they do and the way the response occurs. So the Mobile Crisis Team actually came on board as a result of several officer-involved shootings of mentally ill clients that had taken on for a period of time. Also, there were high levels of incarceration of crimes that were better served, better addressed through behavioral health system. We also had clients who were inappropriately placed to various levels of care. So for instance, there was sometimes what we might refer to as unnecessary hospitalization because there wasn't another way to manage the individual out there in the community or to de-escalate the situation. Next slide, please. So these were the three main reasons why the mobile crisis team came on board. So the mobile crisis team provides real time, which really means we respond immediately to the caller. The call for the mobile crisis team occurs through our behavioral health call center. Our behavioral health call center has a 1-800 number, and through that, that's how individuals are able to call us. So we provide crisis screening, meaning right there over the phone, we can listen to what the situation is, be able to provide some form of crisis intervention over the phone before we deploy someone to that situation. We also provide crisis assessment. Like I said, we do the 5150 evaluation and determine whether the individual meets that hold or not. And if they don't, then that's where we provide the linkage, the referrals and resources that are out there in the community. And I'll talk about those resources a little later in another slide. We also do some form of crisis negotiations and hostage negotiations, and that's slightly different in the sense that we're not out there being the hostage negotiators per se, but we work very closely with the police officers and have sometimes taken the bullhorn to talk to the individual and try to de-escalate the situation. So I just wanted to make that differentiation that we're not necessarily the crisis negotiators, but we do participate in helping to de-escalate the situation. And of course, the mobile team responds in the disaster situations. During the Gilroy fire, staff went out to assist in those situations. Also during the Gilroy shootings, the staff went out as well. So we do respond to other situations also within the county as it occurs. Next slide, please. So what is an acute mental health crisis, right? Sometimes people are wondering what that is or what is that criteria. And so clients evaluated for a potential 5150 hold. And that 5150 hold is a psychiatric hold, right? So it's based on their current presentation at that particular time. It's danger to themselves, which is the DTS, or danger to others, which is referenced as DTO, and grave disability or gravely disabled. And this is where the individual is unable to meet their basic needs for food, shelter, and clothing, or self-care due to a mental health disorder going on. And this grave disability is usually the piece where sometimes the peace officers need our assistance as clinicians, because it could be sometimes difficult to determine grave disability. Also, another piece of the grave disability is not oriented to self, place, and task, and unable to advocate for themselves. So the individual has really decompensated, is usually the word we've used in some situations to determine grave disability. Next slide, please. So really the goal of the mobile crisis team is to meet the client's needs. 80% of the clients that we assess are not placed on a 5150 hold. So we do provide a lot of linkage to the necessary resources. So as I mentioned earlier, we might be called out to a scenario, to a situation where either by a community person or a family member or a provider, anyone could call us. And if the individual, we could talk to them and able to de-escalate the situation. And if the individual does not require a 5150 psychiatric hold, then we have these other options where we can send the individual right away too. So we use the Mission Street Sobering Center is one of those places where we've placed individuals or referred individuals who don't meet that 5150 requirement. We have the Crisis Stabilization Unit, which is located over by east part of San Jose. And we refer individuals there as well. We have the Blackbird House, which is a peer respite program, which an individual who is having a hard time just managing in the community can come out to the peer respite home. We also have a mental health urgent care, who's, it's a walk-in 14-hour a day program where individuals can walk in. We have psychiatrists and clinicians there as well. And finally, we have the in-home outreach team. So the mobile crisis team, similar to how we have the peers on the PERT side of the program, we have the IHOT, which is the in-home outreach team. And this team is made also of peers, clinicians, and family advocates. And so these group of staff basically work as after hours and aftercare coordinators. So again, if an individual cannot go into one of these areas that I've mentioned earlier, the IHOT team will continue to work with the individual. So the individual moves onto their caseload, and they have up to 4 months to try and engage the person, offer them services, and eventually refer them to another outpatient program. Okay, thanks, Jan. Move to the next slide, please. So who is our mobile crisis response team? A mobile crisis response team are clinicians. We partner with law enforcement agencies throughout Santa Clara County. We have 11 full-time coded clinicians or clinical staff. These are made of psychiatric social workers and marriage and family therapists. We have 3 student interns. We have 5 on-call staff because it's a 24-hour, 7 days a week, sorry. So we do have on-call staff, and we have 3 law enforcement liaisons. And these folks are referred to as law enforcement liaisons because these are retired police officers who we contract with in behavioral health, and they help support the mobile crisis team. Next slide, please. Just wanted to talk a little briefly about the law enforcement collaboration. As I mentioned earlier, all of our calls, almost all of our calls really, which is about 96% of the field visits, include a law enforcement officer. So it's either the law enforcement officer or the law enforcement liaison. We provide consultation to the law enforcement officers for chronic cases. So for instance, a law enforcement officer may call us over the phone, and we have a situation where they're not truly sure whether the individual meets that 5150 criteria. They will consult with us and talk to us, and through talking and discussion and really talking about the symptoms of the individual, we may be able to give them alternative places to refer the individual, or help de-escalate the situation just even by talking to them over the phone. But we work very closely with law enforcement officers, especially with individuals who frequently call 911. Sometimes there are folks who just call 911 for the sake of calling, right? Who have become a nuisance to the public or to the community. And so we work very closely with law enforcement officers to help engage those individuals in treatment. We also help to keep the law enforcement officers off the 6 o'clock news. And that's really to help them manage some situations from it getting out of hand, right? We advocate for clients' needs when we meet with the law enforcement officers. And we also, they help to ensure the safety of the clinicians, because sometimes we're not sure where we're walking into or what the situation is. And so they help provide that safety net for us before we engage the individual. And the plan is for both of us to work as a team, right? Or to work together to serve both the client and the community. Next slide, please. So when are we available? Like I mentioned earlier, we are 24/7. So we are truly available Monday to Friday, 8 a.m. to 8 p.m. But we do have staff, and that's where those on-call staff that I mentioned earlier come into play. We have those on-call staff who, take calls and are deployed times after these hours. We've noticed that sometimes the hours until about 11 is when we get the most calls, 11 p.m. And then after that, we get calls here and there from the police officer. You can reach us through our 1-800 number. It's 1-800-704-0900, option 2. So this is our call center, a behavioral health call center, like I mentioned earlier. And really option 2 is a crisis line. So the moment you hit the option 2 button, you would get an individual live who will talk to you and help triage the call. LEOs have a dedicated number. So our law enforcement officers, we do have a separate number just dedicated to them because they require that quick response, right? And so we are there, and that phone number is really dedicated, and we have staff who rotate on calls to manage that phone line. So we do respond 24/7, even though we have a reduced staffing capacity outside of these 8 to 8 p.m., but we do have the after-hour staff, right, and our on-call staff who provide that additional deployment. Next slide, please. So where are we located? We are everywhere in Santa Clara County. We cover from north to south, east to west of Santa Clara. We are located in the Valley Medical Center, right there on campus. And currently, because of the pandemic, the COVID-19, staff are deployed from their homes. It actually has made it a faster response because now we deploy staff based on the area where the call or the crisis situation is occurring. So staff gets there within 20 to 30 minutes of the first call that comes in. And then we also have a staff person located in the Gilroy area. And that person is also there Monday to Friday, and they respond to and work very closely with the law enforcement officers in the Gilroy area, which makes it quite easier because he's very aware of the neighborhood and has really been instrumental in helping address some of those frequent callers and individuals who have had a hard time engaging in treatment. Next slide, please. So as I mentioned earlier, you can access the mobile crisis response team through our behavioral health call center, which is the 1-800 number. Again, we have the English option where you press option 1. We have Vietnamese speaking and Spanish speaking. We do have other languages like mentioned below here. but we always make sure that these 3 languages are available 24/7 anytime anyone calls. We also have access to a language line. And so if an individual, if one of our staff cannot provide the specific language that the individual caller has, we would connect with the language line, and we will be able to respond to that situation. We also have the option whereby we sometimes are able to reach 911 directly, so we can call a 911 dispatch if we think while talking to the person who may be in crisis that it is a very dangerous situation. We would call 911 rather than having the individual over there do that call. So we have that ability to do that as well. Next slide, please. So recent updates. In the month of December 2020, we saw over 500% increase in services provided compared to December 2019, where most, so we did have a big increase in the number of calls from the community. We screened over 3,200 calls in 2020. And there's been a sharp increase in requests due to COVID-19 and the strains. And also a lot of, also as a result of the concerns around police use of force. So that's also another reason we've seen an increase. Law enforcement officers are most frequent callers. So we track where the calls are coming from and which law enforcement agencies are calling us. Clinicians so far have averaged over 200 plus field visits apiece each day, each year. That's the number of calls that is coming up there. And recently, we also had San Jose PD expand their dedicated officer program to 5 days a week. So in the past, we had the San Jose PD had an MOU where they were providing us, since they're our most frequent callers, they decided to provide us dedicated officers so that we will meet that real-time requirement, right? And so immediately there's a call, they have officers dedicated who would come out to respond with the mobile crisis response team. Next slide, please. So here is a graph that just shows the trends and the increase in calls, like I had mentioned earlier. You can see that starting in January, so the program started in 2018, and you can see the blue colors are really 2018 and the number of calls we got. And then in 2019, you see how the calls started to increase gradually as more folks in the community became aware of the services that we provide. And come 2021, you see the increase in the gray in terms of just the amount of calls that we now receive by the community, as well as the police and everywhere else. So there is a huge jump now in terms of the number of calls that we're getting on average. So you can see for the month of December how many calls that we got. Next slide, please. And that's it. So I'll give this back to Jan to talk to us a little bit more about our community mobile response program.
Thanks, Margaret.
Thanks, Jan.
All right, before we get started on describing what the current program looks like, I thought it would be helpful to provide you a bit of context about the funding source for this new project. So this new project is intended to be a Mental Health Services Act innovation project, and there are specific requirements when we fund new projects using this funding source. So you see in the next two slides, there's two here that you see. An innovative project must do one of the following. One, introduce a mental health practice or approach that is new to the overall mental health system. Two, make a change to an existing practice in the field. Or three, apply to the mental health system a promising community-driven practice or approach that has been successful in a non-mental health setting. The second one that you see here is that if there's a mental health practice or approach that has already demonstrated effectiveness, that's not eligible. The third requirement is to have one of the following primary purposes. So the project itself could have all four or a combination, but at the very minimum one. Increase access to mental health services to underserved groups. Two, increase the quality of mental health services. Three, promote interagency and community collaboration. And four, increase access to mental health services. And lastly, the focus of the innovation project, any innovation project, is to focus on mental health and mental illness. So within our own county of Santa Clara, we do have an advisory group, and we call them the MHSA Stakeholder Leadership Committee. And this committee has been in place since 2005 and has been providing input to the county in terms of planning and implementation activities. The team, the committee members are comprised of 30 members, of which 2 members currently represent North County. We have Mary Glonner, who is from Project Safety Net, as well as June Klein, who is the Vice President and CFO of Palo Alto University. So now I've given you some background on MHSA Innovation and our Stakeholder Leadership Committee group. I'm going to now describe to you the timeline. If you look to your very left, you can see that we've started this planning process last year in August. That was when our stakeholder group said, you know, given the current situation, social equity, race equity, and with George Floyd's killing, the community members really wanted to utilize a community-based approach around mobile crisis. And so from the left that you see there from August to November, we had a lot of planning input session that was able to generate a few programmatic elements, but that was not quite enough. So we then held additional planning meetings, in all about 13. From December to January. And it was really to target specific groups, so specific ethnic groups within our own county, such as our African American, African ancestry community members, Chinese, Filipino, Vietnamese, Spanish speaking, as well as, you know, the focus is consumers and their family members, and also family members who have lost loved ones. We were able to also obtain feedback from clinicians who provide services out there in the community. We really got good feedback from that. And you can see here that we're currently, where you see the green arrow, we're really about to close out the 30-day public posting of the draft plan. We will be holding a public hearing with our behavioral health board next week on the plan. So what did the additional planning input session look like, and what did we ask? Well, we had really specific questions. We wanted to know about what they wanted the vehicle to look like, feel. In terms of the telephone, did people want a 10-digit number or a 3-digit number? In terms of the dispatch and workflow, what is the workflow that they would like? So at those meetings, we showed the Cahoots triage and asked specific questions. What do you think about this current flow? Do you have any recommendations or adjustments to it? Also, there's the call center component. One of the things that was really highlighted during the earlier planning input session was that they wanted a call center that was separate from the 911 system, the 311 system, or even the behavioral health call center. They wanted something that's standalone, something that's carved out, and something that is provided by a community-based provider. In addition, we asked them, what about the on-site field team, the folks that go out there in the field? What would you like them to be? What kind of positions, what kind of classifications would you like? So all throughout December and January, we asked specific questions. And throughout all these, there's various legal aspects, obviously, in regards to mobile crisis and getting people care. So that also was addressed at that time. So from those planning input session, this was what was generated. So the innovative approach is to have family involvement, have it be prevention focused, access through a trusted community phone line, have the vehicle be trauma informed, and having community collaborators. So in terms of family involvement, encouraging family members in all aspects of the process, provided that the consumer and client provides and authorizes family members to be part of the process, from the phone screening to ride along to the hospital admission. And then again, when you think about the very first slide that I showed, this is more of a prevention focus, so lower acuity situations, diversions, and also being able to provide the client and consumer pre and post crisis needs as well. And then, as I mentioned, people really gravitated towards a 3-digit number. Some comments included that if you're in a crisis, it's easier to remember a 3-digit number as opposed to a 10-digit number. In addition, this 3-digit number could be really known within Santa Clara County. So that was something that people noted as in terms of promotion and community collaboration. Eventually, with having a distinct number, people within our community can become more familiar with the program. And then having a trauma-informed mobile vehicle. So having a vehicle that that helps cater to the individuals we're helping, and I can go over that later in a later slide. And then also having community collaborators, building a mechanism for having that continuous feedback to address and assess whether or not is it working out as intended. So with an innovation project, we're testing something new within our community, and through that process, we evaluate the efficacy of the model. And currently, the 2 proposed geographic areas based on input are in South County and San Jose. So that takes us to this particular slide. During our planning input session, we showed a map of Santa Clara County, and there was a lot of emphasis where people wanted San Jose as the main site with a priority for East San Jose, and then for South County, specifically around Gilroy. And then if there's enough resources or funding available, you see there under 3, 2 potential sites, an expansion within South County to serve Morgan Hill, and then North County around, some folks said Sunnyvale, Mountain View, but around serving around that area. And this particular slide was very important to our planning group and stakeholders, and it's really to describe what do we mean by crisis. So I'm going to pause here so you can all read before I take you to the next slide, but it's essentially how are we defining crisis in terms of this new program? And then many thought that it would be helpful to provide context in our description. So we provided in the second paragraph that you see here, why this program is being very highly advocated by our community and what this program is all about. So I'm going to go ahead and take you to the next slide. So this is the CAHOOTS dispatch workflow. And this is the workflow triage that we showed at the planning input session in December and January. So you can see from the CAHOOTS model, there's a call that comes in. They utilize the 911, 311 system where the communication center would then assess what the service need, would either deploy EMS or police or the mobile crisis team. And then you have a de-escalation if there's a need, a transport to the hospital, service provider, or shelter. So from our own community, we've adapted the CAHOOTS model and made some slight adjustments. So it's still pretty similar at the very top, but many of our community members mentioned that if I call in and I call in the call center, I want somebody on the other line to be able to assist me right away. And perhaps it doesn't need or require a deployment of the on-site team. So you can see here on the right-hand side, if I put my cursor, you can de-escalate over the phone. And then you see at the very bottom, that also another important request and need is to have follow-up. On the left-hand side, where you see a dispatch field team would be deployed, they would then assess whether or not they could assess and de-escalate and resolve the situation, or if there's a need to transport the individual to a hospital, a service provider, or a shelter. Throughout this process, we're going to have community collaborators in place. I'm going to take you to the next slide. And our community collaborators comprise of various components. We have the outreach team, the community and neighborhoods, some service resources, community leaders, de-escalation training, ethnic cultural norms, and advisory group. And you'll see that there's yellow and green arrows. So the yellow is community informing. So that's always going to be ongoing. And then the green would be the sharing of the information. So it was very important for people, if you go back to this particular slide, is that it's about education, about triaging appropriately, and knowing who we can either, if a dispatch field team is deployed, they do the assessment and de-escalation as needed. But then if there's others where it may not be appropriate to dispatch the CMR team, it was really important to have community collaborators so that they, meaning the neighborhoods and individuals, are aware of county programs and other services where we can take a person to that may not be served well with this particular program. So the call center, so there's various components. The call center, many people said we need to have this operational 24/7, 365 days of the year. Again, the request is to have this community-based operated. And then you can see the staffing that's been asked of our community, and based on the 24/7 operation, it would require one FTE, a program manager. That would be a behavioral health clinician that's licensed or license waiver. And then a big bulk of the staffing would be 13.5 FTEs. That would be, as you can read here, comprised of peer specialists, peer family, and paraprofessionals. It's very important that for our community members to have people employed and be part of the call center who have lived experience, and then also having volunteers as well, but have it be comprised of the volunteer up to the 25% of the call center team to make sure that it is operational 24/7, 365 days of the year. The CMR team, so that's the on-site field team that would be deployed 24/7 in two service areas, the San Jose service area and Gilroy. So we would have two distinct CBO providers. It could be the same one. It would depend on who gets selected through the RFP process, but each one mirrors each other in terms of team. So you can see we'll have one FTE who's the community collaborator, engaging the community, informing, and having and making sure they establish some way to let people know about this new program and engaging the community members along the implementation. We also will have a program manager that's going to be that needs to be licensed, and then the on-site field team will always be comprised of 3 members: an EMT, a crisis intervention worker, and an outreach specialist. So there's always going to be 3 members. So if I call in and a CMR team needs to be deployed, this is always going to be comprised of these 3 members. And you see the 4.5 FTEs, that would be to ensure the 24/7, 365 days coverage. So overall, per service area, it would require 16 FTEs. In total for this program for San Jose and Gilroy, we have 32 FTEs. And similar to, and I do want to note again, similar to the prior slide for the call center, as well as for the CMR on-site field team, there's a desire and ask for staff to have lived experience so that when they are deployed, they know how it is to be in the person's situation and be able to serve them in a kind and respectful way. So the vehicle, here you see a vehicle, a picture of the Cahoots team out of Eugene, Oregon. And you can see that they utilize a white utility van. And you can see inside the van that there's equipment. So this is one of the things we also ask of our stakeholders. How about the exterior, the interior of the vehicle? So for the exterior, they wanted something discreet, nothing too official. They don't want anything that's associated with, police officer like blue, shouldn't be red, it should be a neutral color. And it should be, since it may be going around neighborhood, not to have a stigmatizing presence. In the interior itself, a lot of folks would like it to feel comfortable and something welcoming. So one of the things people mention is having fidgets around, some calming objects, potentially having water, something comfortable to sit on or even lie. And also if you're in a episodic state where light may be sensitive to light, limiting the type of lighting or working around the lighting around the interior of the vehicle. Another family member noted that if somebody is claustrophobic and if the budget's there, how about having a plexiglass roof? So once we get through the whole community planning process in the interior design, we'll take that back to our community to get more refined ideas about the potential interior of the van. And then also another side note, that sometimes people may not want to go inside the van or may be claustrophobic. So having chairs that team members could take out to then be able to sit down and have a conversation and discussion with the client. Through the planning process, people thought it would be a great way to have a design contest to help promote the new program. So as part of the program plan, the current plan is to hold a countywide contest in which, as you can see here with Eugene, Oregon, they have a specific logo, but that would be the one that we would use for the van and promotional materials. And then also it's a great way to have our stakeholders, the community members be part of the process and also helps with program education. And then in terms of family involvement, there was a lot of emphasis that the clients come first. So although there was a lot of support for having family involvement, we do need to respect the client's wishes at any given time. And then also there's currently a form, it's called AB 1424. That is one of the form that NAMI of Santa Clara is promoting to help provide information about the family should a situation arise and how to go about helping care for the family member. And then outreach, again, with the community collaborators, they're going to be responsible for community engagement, working with various groups, leaders within the community, also promoting this new program through social media accounts. So one of our planning input session for the TAY group, which is our 18 to 25 years of age, said it would be great to have social media account to use to help promote, show the inside of the vehicle, do a walk through the vehicle and having pictures, and then engagement with a community-based provider. So not just the CBOs providing the services, but also engaging others. Again, when you do the triage and potential transport to other services for the client, having that knowledge to know where we can take an individual to. And then most importantly, also working with respected community members, such as faith-based leaders. And then to end this portion, so with any innovation project, it's all about learning, having learning goals. What is the intent of this project? And throughout this process, we're going to have an evaluation conducted and which will be contracted out. So here are some of the questions that's going to be posed through our evaluation plan, such as, will this new program lower the incidence of clients being transported to the hospital or jail? Will this new program encourage community members to seek help when needed? and will collaborative approach help increase use of the program? So many members during the planning input session do not have shared that they don't call for their family members or they don't call for themselves because they fear of police involvement and what that may lead to. And so perhaps having this community-based approach where there is no police officer involvement in the care, maybe it will help increase use of services and increase folks to actually seek out help. So we would have a community advisory committee board to meet that will be meeting quarterly, and we'll have various representations that you see here. So in terms of the budget, there's 4 main components: one-time related expenses, the call center, which will be CBO operated, the field teams, and other county expenses. So the first year of program implementation, there are one-time expenses in the amount of $239,000 with the purchase of the vehicle. The bulk of the costs in terms of the van is the retrofitting and the reconfiguration to be able to make the inside be trauma informed, make it comfortable for clients and consumers. And then with the design contest, the winner would get a $5,000 award, and then we would have a design vendor that would then transpose that design to workable media. So this is the second budget component, which is for the call center. You can see here the annual amount is about 1.3 with a 5-year project. It'll amount to about a $6.7 million cost. And the big bulk of it is for the staff. The third component is the main bulk of the project. And this is for the 2 service areas that I had mentioned earlier. So you can see the San Jose service area has a 1.765 annual budget. The same thing with Gilroy with an annual budget for this particular program component about $3.5 million. Overall, a $17.7 million program budget for 5 years. And then lastly, we do have some expenses that we'll be managing as well. So we do have an evaluation contract budget that we're setting aside in the amount of $50,000. And we also have a program manager that will be overseeing this program throughout the term of the 5 years. So in total, the 5-year funding request under the Mental Health Services Act innovation funding amounts to $24.8 million that you see here in green. We add up the county general fund from the Board of Supervisors. In total, this 5-year funding would amount to $25.7 million. So where are we now with the planning process? So it's been quite lengthy, but fast at the same time. And I can't believe that the 30-day public posting will be ending on Sunday. But you can see here that once it ends, we are convening a meeting with our stakeholder group, which is open to the public. We will be providing updates in terms of the plan, share any comments that we received during the public 30-day public comment period. And then 2 days later, we will be holding a public hearing with our behavioral health board on the Cmrp project. And then the following week, we will be requesting the County Board of Supervisors to do a few actions such as approving the plan and authorizing the department to submit the plan to the state. So ultimately, we do need to request state approval for this new project after we finalize the local planning process. And we're hoping to be able to present to the OAC, which is the Mental Health Services Oversight Accountability Commission, who provides oversight on new innovation projects, hopefully by April. So we're gonna go ahead and open up for some Q&A or comments that you'd like to make on any of our programs that we covered here.
Thank you for the presentation, Ms. Morral and Ms. Abilar. That's very interesting. And I'm just amazed because there's so much that we don't know about. But I'd like to open it for comments and to questions to my to Councilmember Stone and to Councilmember Tanaka.
Just a quick question. Is it possible for us to get a copy of the presentations to email
Yes.
it so we can flip through it? Like, can you email it now? For this one and next item too.
Councilmember
Yes.
Stone?
Thank you, Chair Koo, and thank you for this presentation. This was really helpful to get a better sense of what the county's been doing, and nice to see, and really impressive to see the amount of work that has gone on in a really short amount of time. So I guess I'll kind of go through my questions, kind of bringing up on the 3 different programs you outlined. So the first one on PERT. Is a clinician riding along with law enforcement?
Yes.
Okay. And how many PERT teams are on duty at any one time?
So it's 3 staff that will be on duty.
Okay, so there's 3 staff members with 3 separate police officers across the county.
Yes, although we are still in the hiring process. So at this time, we only have 1 clinician hired who's
Okay.
working directly with the sheriff department.
And so who's the lead on kind of first contact and the ongoing interaction throughout the engagement with the person? Is it the police officer? Is it the staff member?
So for the PERT team, it is the police officer. But for the mobile crisis response, it's the mobile crisis team that goes out there first, but they do wait for the police officer to get there, and then collaboratively, they go out to the particular location. So it varies depending on who gets called out.
Okay, and I guess in kind of reality, does it actually work in that way where the police officer will truly kind of go about it in a collaborative process? I think oftentimes there's just a tendency for police officers to kind of, I mean, their job is to take charge, right? And so I think there's a tendency for them to be able to do that in these situations. So have you seen that it really is a collaborative process, or are these clinicians and staff members having to kind of take a back seat?
It is a very collaborative process. We actually meet at a different location. So we may meet a few streets down and wait for the police officer to get there. And then we all walk towards that particular location. So it's that collaborative. And again, they're the ones calling us sometimes. So they called and they would wait for us. This is why San Jose PD actually now have dedicated officers so that we don't have to wait for a police officer to be available, right? They have staff who are now dedicated. So once mobile crisis response calls them, we meet at a specific location. We talk a little bit more about the scenario, and then we all walk down to the location.
And so does this help prevent officer-assisted suicides? Are these clinicians able to kind of? I can't imagine being able to prevent a police officer from pulling a gun in a situation where they feel that their own lives are in danger. But is there that close of a kind of a partnership and collaboration here that this is what it's meant to do?
There is a lot of collaboration. I mean, again, remember, we're called into a situation where if it involves a behavioral health related type of situation, right? So we do have several CIT officers who are crisis intervention officers who tend to work with the mobile crisis response team. So you're talking about 2 different scenarios. And the scenarios where we are involved, there's a behavioral health situation going on, and that's why we're there. That's that's different from another situation where the police arrives there and managing the situation, realize, okay, we could benefit from a behavioral health assistance, and then we get called into that situation.
That's helpful. Okay, so on the, sorry?
Councilmember Stone, I think I forgot to go to public. Could I hold,
No problem.
have a
Yes.
hold, and then we'll go to the public, take questions and
Absolutely.
comments? Thank you. Thank you, Ms. Fong. Could you help me get the question, call the attendees?
Absolutely. If there are any members of the public who'd wish to speak on this item, if you could please raise your hand at this time. Chair Koo, it looks like we have 5 speakers at this time, and Kevin Ma, you are up first.
Evening, council members. My name is Kevin Ma. I'm a renter in the Ventura neighborhood, and I thank the city for paying attention to this issue very deeply by learning what the county is doing to ensure that all members of our community deserve the medical attention that they deserve, rather than the current scenario where we send cops everywhere and then see what happens. We've seen cases in the city where that has not done so well. Most famously in 2019 with the stroke case due to a mismatched 5150 case. As such, we also recognize that a lot of people in our society do deserve the help. Unfortunately, mental health in our society has been greatly defunded and devalued over time, even though, as you can see from the 2020 stats from the county, that it's more needed than ever. As such, I do want the city to consider creating a Cmrp-like program in the city. If not, just try to collaborate with neighboring cities as well as the county to just fund another section for the North County, because we've seen a dire need in this case, as we saw with Project Safety Net, of a lack of enough mental health resources, or these connections to mental health resources, to do it correctly. And I do support the county program of trying to separate it directly from 911, because there is distrust necessarily about the police about entering these scenarios. And if you can make at least any situation better so that more people can use it, I feel like the city should make the investment for that. As we also know that the Palo, as you sent direction to the city staff to determine for the Palo Alto police contract, union contract this year, that we should be sending social workers instead. And social workers on average are probably much cheaper than police for various reasons. And as we know, the city's finances do require us to be cost cutting. So we should be cost cutting against, these large amounts of pay currently guaranteed in the police union contract and fund them to more useful items in our budget. Thank you.
Hi, can you hear me okay?
Is this Emily?
Yes, hi.
Hi, please go
Excellent.
ahead.
Thank you. My name's Emily Lacroix, and I'm a renter in the Southgate neighborhood in Palo Alto. And I want to echo some of the sentiments I heard Kevin say, and that I really appreciate the county's efforts to think of alternatives for responses to mental health emergencies. I find the new CMR program to be a really encouraging step forward for our county. However, I still urge the city of Palo Alto to explore their own city-based mental health response team, similar to the Cahoots model. So, or we could think inspired by CMR in this case. Mental health emergencies, in my opinion, should not involve law enforcement officers. It can be traumatizing for the person experiencing a mental health emergency and potentially bring more harm to that person, even if a mental health professional is present alongside the law enforcement officer. In the city of Palo Alto, we know that we actually receive a really high volume of calls that can be better served by mental health professionals. So in 2019, the Palo Alto Police Department received over 7,000 calls that were classified as a medical call, welfare check, or transient complaint, all of which could arguably be better handled by a healthcare professional. Redistributing mental health checks from police departments to civilians, such as in a Cahoots style program, should also be supported at the city level and not just the county. 7,000 calls a year is a very large number. And although we could receive some support at the county level, I do think the city should look into its own program as well. Additionally, as already has been mentioned, this could provide the double benefit of a cost savings for the city. So with the example of Cahoots, which has been highlighted a few times tonight.
Emily?
It looks like
So in brief, if our city does not make its own program, they should fund CMR in the North County, but I still think that funding something within the city government would be best. Thanks.
Thank you.
our next speaker is Olamide Bois, to be followed by Winter Dellenbach.
Hello, can you hear me?
Yes, we can hear you.
So I also want to echo what Kevin and Emily have said before me, namely that I'm thankful for this committee to, sorry, is there an echo? I really can't. Sorry.
Everything sounds fine on our end.
Okay, apologies for that. I just wanted to thank Kevin and Emily for the points they made before and the committee for bringing this item to account. I'm really impressed with the CMRP model that's been proposed. And I just want to echo what Kevin and Emily said in that wellness and mental health checks need to be a city responsibility and funded also by the city as well. And I really want to encourage this committee to take upon itself a proposal that will center this. And I just wanted to highlight, I wanted to elevate the Cahoots model because it does not involve law enforcement. So police only escalate mental health crises. So I'm a neuroscience graduate student at Stanford University, and I think a lot about how studies show that individuals who experience more police contact report more trauma and anxiety symptoms, including suicidal ideation, psychotic experiences, and suicide attempts. There is a nearly twofold higher prevalence of poor mental health among people who report prior police interactions compared to those who don't. Additionally, involving law enforcement in responses to mental health risks individuals' physical safety. Between 1/3 to half of use of force incidents with police officers in America are against a disabled person, and people with untreated mental illness are more than 16 times more likely to be killed by law enforcement. And to echo the points Emily made about call volume and how a stark chunk of calls to law enforcement are around mental health, the call breakdown highlights how much money can be divested from systems of policing and incarceration that further traumatize people and instead redirected towards access to mental health resources, housing, and education. And there's a really unique opportunity here to adopt or create a similar model to the CMRP, maybe in collaboration with neighboring cities or just on a city level, or try to fund such a program on the county level, but to be expanded into North County. Thank you.
Our next speaker will be Winter Dellenbach, to be followed by Patricia Peppa. Winter, go ahead.
Hi. I have something to say, and I also have a question. What I want to say is, first of all, any of these three alternatives are better than none. Any of them are better than none. I have been advocating for Cahoots for what, a year and a half now. I'm pretty well acquainted with Eugene, Oregon, which is the originator of Cahoots, with their program. One of the things, I have a couple remarks though, which is North County and specifically Palo Alto are often kind of at the bottom of the totem pole in terms of getting county services. I mean, PERT has been talked about for a long time now, and it's still not happening for Palo Alto, even though Palo Alto is, aside from the county, is one of the two places that is supposedly designated for a PERT person. One of the notions perhaps for the CMRP program or something like that would be that Palo Alto could go in with a couple other North County cities and possibly share in a program with the expenses that way. Palo Alto financially isn't in the best of shape right now, but it's something that maybe we could develop cooperating regionally with some others. I have a question. Here's my question. Well, let's see. Do I want to say anything else about this? I think that the Cahoots is head and shoulders above the others, only because of the wider net. And it's the wider net that that I'm concerned about. Cahoots isn't entirely mental health based. It's more social based. It is concerned with homeless people. It's concerned with people that have drug problems, alcohol problems. I know some of this also is true of the programs we're talking about tonight. Social workers play a role. Medical people play a role. It's both family oriented, individual oriented. It does have a really wide net. So here's my question before my time runs out. I want to know how wide a constituency the programs would be serving, aside from the mental health emphasis. Thank you.
Our final speaker will be Patricia Peppa. Patricia, go ahead.
Hi, my name is Patricia, resident of Palo Alto, Advocacy Chair, Mid-Peninsula ACLU Volunteer Chapter, and mental health professional. Thank you, Margaret and Jan, for reviewing the various mental health programs and pilots from the county. Ultimately, we need an alternative response for mental health crises in which law enforcement is not the primary responder and is not even involved unless needed. The well-established Cahoots program in Oregon only calls for police backup 2% of the time. Law enforcement acting as the primary responder leads to overutilization of emergency departments, unnecessary arrests and incarceration, and the risk of confrontation leading to deadly force. As Emily mentioned, mental health related calls make up a significant portion of our 911 calls and are a grossly ineffective use of our law enforcement resources. While PERT and MCRT are great services, the common denominator is still law enforcement when they don't need to be in the equation most of the time. Their presence alone can cause anxiety and escalate the situation. As Jen mentioned, people even avoid calling 911 for this reason. The county CMR pilot program modeled after Cahoots is promising and well thought out, but unfortunately for us, it's starting in South County. I agree with the previous speakers that we need to implement our own system, whether it be partnering with neighboring cities or creating one on our own. Cities across the nation are implementing their own programs. For example, the city of Albuquerque is creating a community safety department, which will dispatch social workers, peer support workers, counselors as first responders to 911. Implementing a program like this will have upfront costs, but will save the city in the long run. We could look into other various funding models. A leading solution to the crisis care funding puzzle is to model reimbursement after the physical health service counterparts already in place. We need to shift the burden off local communities to the person's health insurance plan that by law or contract is actually responsible for covering. For example, Arizona has a comprehensive crisis system in which they bill Medicaid for crisis calls. So that's an idea for funding. But please consider reimagining the way we manage public services here in Palo Alto so that it's more efficient, inclusive, and equitable, and consider a Cahoots-like program for the city. I think we need to ultimately shift this work off law enforcement to more appropriate responders. Thank you for your time.
Thank you, Ms. Baum, and thank you to all the speakers. Before I go back to Councilmember Stone, there was a question that Ms. Dallenbach had posed. Would you be able to answer that, either Ms. Morale or Ms. Obelar?
For the CMRP program, I can talk about that one. Since the primary funding source will be the Mental Health Services Act under innovation, and the focus would be on mental health illness. Also, if the individual has a co-occurring disorder, let's say substance use, that would qualify.
And that's because it's under the innovation, which is you have these criterias that you have to fill, right? So, and I understand some of them is, it cannot have happened. I mean, it cannot be in another program that has already experienced. It's about finding something new.
Correct. And the Mental Health Services Act primarily funds mental health programming or mental health programming with a co-occurring component such as substance use. It's not to say if somebody were to call in, we can also provide them assistance and possibly triage them to appropriate care, but primarily with this project, due to the funding source and the requirement per California Code of Regulation, the focus is on mental health.
Okay, thank you so much.
You're welcome.
And for the PERT and MCRT, the focus is really on crisis stabilization and crisis intervention. So if an individual is not necessarily having a crisis, a mental health crisis and all of that, we may not necessarily come out there. And that's where I think Supervisor Stone was talking about possibly someone else coming out, right? Yes. So ours is focused more on mental health and crisis stabilization.
Thank you. Councilmember Stone, would you like to continue?
Sure. Thank you, Chair Koo. And then thanks to all the public commentators. I thought all, I mean, just really, really well said and obvious and clearly well researched as well, which they were. We can have a longer discussion with all of them. Okay, so moving to the MCRT. You touched on this, but I want to just be clear. Do members of the public have to call in to a specific number to get this service, or are 911 calls triaged?
For MCRT, members go through our call center. So we do have the 1-800 number that I showed there, and anyone can call in. So it could be the community, it could be a family member, it could be anyone. And then, of course, we have the dedicated officers line.
Okay, and what's kind of like the average response time for one of these teams to be able to reach a crisis?
So I mentioned that earlier, that our response time is actually quicker now. It used to be about 60 minutes, but our response time is quicker. But number one, because of the pandemic. The other piece is because folks are working from home. So we deploy staff now, you know, based on where the crisis or the situation is occurring. And sometimes it could be very close to where the staff is.
So what would be, do you have the information as far as like what would be the closest team to Palo Alto?
Mm-hmm. We have a calendar of all the staff who are supposed to be deployed each day and each time. And so based on where the call comes in and we get a sense of the location of the incident, we will deploy the staff, the staff who are working that day, who are closer to that area.
Right. I guess what I'm trying to understand, try to get a sense, like most of these services and Ms. Dellenbach addressed it really well. You know, I think one of the great frustrations in Palo Alto is that most of these services are geared for San Jose, South County, and so kind of oftentimes we are left either being kind of last in line for these services, or these services are really removed from North County. So do you have a sense of like how quick it would be to be able to get one of these mobile units to Palo Alto in a crisis?
So I think that maybe I wasn't very clear then in terms of my response. With the pandemic, right, it's much quicker. There's not so much holdup. So we are able to get there to Palo Alto or many parts of the Bay, Santa Clara much quicker. Of course, during busy hours, it's not always as quick because of the traffic. And of course, that's where the distance comes into play. But we treat Palo Alto not different from any other area, as long as the person meets the criteria and the situation doesn't involve a mental health crisis, we will get out there.
Yeah, and I appreciate that. Like, I wouldn't expect that Palo Alto would be treated differently, but there is just kind of like the geographic reality of being the most northern city in the county, and oftentimes these programs coming out of San Jose, we see the economy opening up again, traffic returning, and so you're saying the response is quicker now than an hour. Does quicker mean we're looking at 20 minutes, 30 minutes, 40 minutes? Because I mean, as far, I don't need to tell you, I'm sure every minute in these situations are critical. And so I'm just looking for a kind of a ballpark estimate on kind of how long somebody would have to wait if they make a call from Palo Alto to get one of these mobile response teams.
So our typical response time, it's been running between 20 to 30 minutes. Now in Palo Alto, I'm not sure in terms of exactly how many minutes it takes us to get there. What I would say is ordinarily we do have a window of 60 minutes to respond to the call. So that's our window of time, but we have been able to respond quicker as a result of the pandemic and not too many people being out there on the street.
Okay. I can see that is a kind of complication here when we're trying to look towards moving from a police response to having these mental health professionals responding as just far as kind of response time up here. I would imagine people would be hesitant to make that call, recognizing that it could take that long. Thank you. I appreciate that answer. So the data shows an upward trend on the number of calls, which is great. People are really learning about the service. So are you seeing a corresponding reduction in the number of officer-involved shootings and use of force compared to that upward trend?
So we haven't really done the data on that part of things. What we are tracking mostly is our diversion rate. So how many individuals ended up in the being hospitalized, right, as a result of or not being hospitalized because we came out and mitigated the situation, or number of people who were diverted from incarceration, or number of folks that we were able to link to services. So the other piece in terms of officer involved shootings, we are not the ones really tracking that.
Okay. Those other indicators you just mentioned, we are seeing a downward trend on those.
Yes.
Great. Chair Koo, should I continue with my questions, or would you prefer to see if anyone else has, and you can come back to me? I don't want to take up all the airtime.
No, go ahead.
Okay.
Finish up. Thank you.
Thank you. Okay, so moving on to the community mobile response program. Very well done. I've been a big fan of the Cahoots program. I've studied it closely. I like a lot of the modifications that you've made to it. I'd love to learn more about it, but it seems like we're heading in a good direction there. So I saw we're focusing on East San Jose right now, then South County, and as frequently as it is, I'm sure Palo Alto and North County will kind of be at the end of that. Do you have any estimate? So on there, it said maybe years. Any estimate on how long until Palo Alto will be able to access that program?
So in terms of the service side, so that's the question that we post out to our stakeholders. If you recall that slide with a map of Santa Clara County, we asked that question: where should the service site be? So those planning input sessions, those 13 planning, and we had quite a number of people attending those meetings. They raised their hand and said, we want San Jose, we want South County. There were only a small number that noted North County. So those service sites that you see in the plan was based on stakeholder input.
And was that based on just kind of like the power of advocacy at those meetings for kind of maybe city and local officials in those parts of the county just being better at advocating for those services? Or is that just based on data showing like this is where the need is, and so that's where we're directing our resources?
No, we actually pose the question to, so our meetings are attended by various folks, community-based providers, clinicians, consumers, family members of consumers, and not necessarily public officials, but really community members. We had a variety where we had a group just specific for Spanish-speaking community members that was really well attended. They all said San Jose. So it's all dependent upon, I do encourage all of you, if we have a new innovation project, you have my email, that you encourage more of the North County residents to participate and raise their hand and say, we want North County. But throughout our planning process, what we heard was San Jose and South County. So hopefully that gives a little bit of the feel of the stakeholder process.
It does. And yes, in the future, we want more North County, please. So at this point, are there opportunities for Palo Alto to be able to maybe pilot in the program, or is like is that kind of part of the process closed and now we're waiting to be able to until we're in the phase where Palo Alto can access?
So right now, there's still a desire, if there's funding available, to include, again, Morgan Hill for South County and North County as well. So right now, what you see is a $24 million ask around the mental health services innovation funding. That really tops us in terms of the county funds available for innovation funding. But if there's other funding sources that perhaps City of Palo Alto can offer to then enter, and stand up a CMR site in Palo Alto using City of Palo Alto funds, that could potentially be added as part of the program. Now, in terms of the planning process, we would then need to, since the community planning process ends on Sunday with a 30-day public comment, and then we do have a public hearing. If there's a comment made about we have additional funding that we'd like to offer for this new site, we could potentially include that and share that with our public and stakeholders and our behavioral health board members as a placeholder. So not to do a rewind on the community planning process.
Great.
I hope that answers your question, and if not, let me know.
A little. I mean, I think it would be helpful if you could provide any necessary information there to maybe to city staff, for them to be able to better understand what the ask would be from the county as far as Palo Alto funds to be able to be a part of that. I mean, I think that would help guide our conversations in the future.
Sure. And I shared the PowerPoint, so you'll be able, if you go back to the slide where you see the service area, you'll see the cost per service area. So that would be like 1.7 million to develop a Palo Alto site.
And if I can jump in, Madam Chair, sorry, for clarification, Jan, is the information that you need for that placeholder a commitment of where the funds are coming from, or is it just a statement that there's an interest in North County were the funds to become available?
So I would note, you can note in your comment that there's interest in City of Palo Alto to explore, which aligns with the comment that was provided early on about having additional, if there's funding available, to open up North County. So it would depend on what type of commitment your City of Palo Alto is offering up. But I would direct you to that particular PowerPoint slide about the cost and how much it will cost to stand up one particular site in Palo Alto. Chantal, does that answer your question?
Sorry, I was unmuting a little bit. I think Ed has a refined version of clarifying.
Sure. Just a quick follow-up action. We'd be happy, Councilmember Stone, thank you for the lead in, be happy to follow up with county staff on that. Jan, one question that would be helpful for us would be a sense of time frame. When will and who's the decision-making body on both your current funding request as well as if Palo Alto were interested in participating financially, to whom and when would that decision be made?
So in terms of, and you're talking about City of Palo Alto funding, right? Right.
Yes, as well as you mentioned that you have an existing ask for funding the program overall. When will that decision be made and by whom?
So it's going to be once the local approval process takes place and the Board of Supervisors approve it, we then submit it up to the state, where we then request for that $24.8 million. So I do want to state that the innovation funding is not limitless. We're at the point where we've utilized everything, especially for this project. So there's no more innovation funding available to add a particular additional site. So if there is an ask to, let's say, participate and build a Palo Alto site, it would require non-MHSA innovation funding.
Can you repeat that?
So non-Mental Health Services Act innovation funding.
I see.
So any other funding source outside of innovation.
And I'm sorry, I still didn't get a response on the question of timing, as well as.
So in terms of timing, the 30-day public posting of the plan ends on Sunday. We are convening a public stakeholder meeting on Monday to share information with the public about any updates to the plan, including comments received. If there are any comments that substantiate a change to the plan, we are then holding a public hearing. So it's pretty fast. So certainly this week would be ideal in terms of providing comment.
And also
Jan,
on this,
sorry, just to clarify, so Jan, if the city of Palo Alto were interested, they would need to be sure to be making a public comment or providing feedback to the current plan that's currently posted prior to Sunday, right?
Yes.
Okay. Indicating interest, if that were the case for the city.
Mm-hmm. Earlier the better, so then we can plan for it for our Monday 1:30 p.m. meeting.
so
Right.
do we know where to go to comment?
14th.
Yeah.
Do we know where to go to comment?
I think we can follow up with county staff on making sure we have the details.
Thank you.
Yes, and just to clarify too, we as the city can make a comment, and also members of the public can make comments during this open comment period as well. Correct, Jan?
Yes, everyone who has participated, and as well as folks that are new to the process, can participate in the public comment period. So Palo Alto residents, yourself included.
Okay.
So Ed, would you need official council direction to be able to do that, or can staff or this committee kind of go on our own and make that request?
Well, that's a pretty big ask in a short period of time.
Yeah.
So, it depends on the level of formality, I suppose, that we're seeking. Certainly, if the committee had an interest in having a committee recommendation would help, as our indication that the council, or at least the subset of the council, has an interest in pursuing this. I don't think it's committing us at this point, but would nonetheless be helpful if it is of interest for the committee, that we could indicate in our letter.
Additionally, I think members of the community in general can make comments as well. So it would be good to encourage the public to make the comments, Palo Alto members.
Yes.
Great. Councilmember Stone?
Okay, so if we miss that deadline, which it's like Like that's a short turnaround. So if we miss that deadline, we're not going to see, Palo Alto won't be able to see these type of services until when would you estimate? Like what year, a quarter of a year that you might be able to give us?
Yes, so it would all depend on the funding availability and in terms of programmatic. So the Mental Health Services Oversight Accountability Commission is the state agency that oversees the Mental Health Services Act funding. So any county that modifies the program or plan, the draft plan, will then be required to, again, do the whole 30-day public posting. But again, if this is what the community wants, then that's what we do. But in terms of the process, we do the same process. We have a convening, share the suggestion with the community members. We do a 30-day public posting and saying this is an adjustment to the draft plan. Likewise, if there is a change in any element of the program, we do the same thing. So it all depends on if there's additional funding that becomes available, or when City of Alto is able to join the effort. It's all dependent on that. But with MHSA, we always have to go through our local approval process and then send everything up to the state. They have a commission, a 16-member commission, where they take, we do a presentation and they take a motion to either approve or not approve. So there's specific rules around this funding source.
This funding source, Innovation 15, right? Is that what it is, INN 15?
Yes.
It's a one-time.
Yes, so MHSA has 5 components. Innovation is the component that allows counties to test out and pilot new things in a time-limited fashion, and that's up to 5 years. And after the 5-year ends, the county, should they choose, and if the program has been effective, can then desire to fund it with other non-MHSA funding, innovation funding source.
But definitely a lot of this, I mean, you've made clear, definitely a lot of this depends on a lot of moving pieces, and I can understand how difficult it is to give an accurate estimate right now. But do you have, I mean, any sense on when Palo Alto, I mean, are we talking 2-3 years, 4-5 years? Any sense of, and the reason why I'm asking this question is trying to get a sense of, we missed this deadline coming up, and now we're looking at a 3 to 5 year gap until Palo Alto can really access this. Then that'll be able to better help us in our discussion. Do we want to look at going on our own with this, or if it's just a year or two that we have to wait, then maybe that doesn't make financial sense for the city. So if you could give any ballpark, that I think would be really cool.
So I do apologize. My internet connection was unstable, so I kind of cut out a little bit, but it sounds to me that you want to just get an estimate. So, with our planning process, it was quite extensive, but it was pretty fast. So in terms of the core elements of the program, it's there. So essentially it would just, if there's a modification to the plan, we then share with our stakeholders. We then ask them, what do you guys think? If they say, yeah, let's do it, we then do the whole 30-day public posting. And then we have the behavioral health board hearing. So, I mean, we can do this within a year, depending on how you would like to move forward with this. In terms of this particular program, what we hope to do is be able to get board approval on March 23rd, and soon after be able to request from the state and present to the state in April, if not May, get the funding at the start of fiscal 22 so that we can do the RFP process and have the program be implemented by early January of 22. So there's a lot of desire for our community members to have this up and running. So we're trying to do this as fast as we can.
So you're saying it's a possibility that we have this program in the county by 2022, or here in Palo Alto in 2022?
In the county in 2022, but if we do include City of Palo Alto, and we do need to modify the plan, we still need to go through the required planning process with our community and ask back to the community, what do you think? And then also offer up funding sources that would fund the site.
Okay, but I might not be clear on my question. If Palo Alto, if we are not a part of this, of getting that site located in Palo Alto right now, given that that cutoff is coming up this Monday, what is your best estimate for when Palo Alto would be able to have these services? Is that 2022 or is that beyond?
That is beyond, just because if the current program plan only includes 2 service sites, and there's no inclusion of other sites like Palo Alto, they would be excluded from the plan. Now, depending on how it goes with the council members here and your decision, we can always modify the plan in the future to then add Palo Alto should funding arise. So it's just depending on timing and availability of funds and whether stakeholders, support the plan.
Okay, so if we're able to get into this, we could be looking at a year from having this program operating in Palo Alto. If not, we're looking at several years out.
Yes, it all depends on our stakeholders and their desire to stand up programs. The one thing that's very core with the Mental Health Services Act is the community planning process, and it's driven by stakeholders.
Okay, sounds good. Thank you. And Chair Koo, I'd be interested in making a motion that the Policy and Services Committee kind of supports this. I don't know how to I don't know how the best way to word that motion at this point to be able to really articulate it, but I'd be happy to move that. I think it's important that the city at least attempts to get one of these sites established in Palo Alto, or at least start the process to be able to see if it financially makes sense for the city at this point.
At least get our name, Palo Alto's name on your list, on the county's list for this program. Is that what you're saying, Councilmember? Yeah. Okay. So, Ed, can you help?
Sure, agreed. And I think we also want to touch base with the Supervisor Simidian, recognizing this will be a county-run program. So committee recommendation that, well, perhaps the staff express our interest in participating in the program, and that will communicate this both to Supervisor's office as well as to the full council.
Do you have a second? Somebody second?
I don't get to make motions, so I'll presume that.
So I'll make that motion. Thank you for your help.
And I'll second it.
Thank you.
You have any comments?
I have a
Stone?
question.
Oh, okay. Go ahead, Ms. Gaines.
I just wondered if there was interest in also having staff have any conversations with regional organizations such as nearby communities. I know that was mentioned, so just wanted to ask that question, see if there was interest.
I mean, for me, yes, there would be interest, but I feel like that might be premature at this moment. My understanding, at least from the presentation by county, was where I don't think they addressed that. My understanding is like that would be a really good, if we're not able to be a part of this program and get a site here, we need to look at moving forward on our own. At that point, I agree. I think the best idea at that point would be to start having those conversations with surrounding communities. I don't know if the seconder agrees.
Agreed. And I was also thinking that, because this is very much the community stakeholders driven, that perhaps we should start include in there the conversations with perhaps Ms. Gloner, and get to know some of the stakeholders and work that way, at least have a dialogue started too.
I agree. So I've spoken on my motion.
I agree to what you said. And I was just wondering if Councilmember Tanaka had any questions or any comments.
Yeah, actually, I've had my hand up for quite some time, but I don't know if
Oh,
you
I'm
can
so
see it.
sorry. I
Yeah.
didn't see it. I'm so sorry.
Yeah, no problem.
Go ahead.
So can I ask a few just general questions? Because I think
Councilmember Tanaka, before you do that, I can hear you. I just wanted to announce that perhaps this is a very interesting topic that we might want to spend more time on it. So our item number, I think 2 is which is about the protocols, the procedure and protocols handbook, that perhaps we should move it to another date, maybe to next month, or the other staff will inform us. Then this will give us more time to discuss. So thank you for those of you who have been here. Go ahead, Councilmember Tanaka.
Okay, sure. Can staff go to the slide that has the monthly trend by year on it, please? The graph, the bar chart. Page 19.
Jan's got that presentation. Or perhaps we do now. Not sure.
So my question here is, it's definitely alarming to see the difference, the stark difference between 2020 and 2019. I guess that's largely accounted by COVID, as you mentioned earlier, right? So how are these cases distributed, these visits? Like, in terms of geography wise, are there mainly South County, Palo Alto, how, like, because this is like, you know, I don't know, 4x, 5x, like the usual amounts. So what's the distribution looking like in terms of the county?
Are you asking in terms of staff distribution?
The field visits.
Oh, the field visits. So, so again, all the calls coming through the call center. So it's a centralized location. And we do have staff calendars set up in there, and that's how that distribution occurs. So it is across the county.
Oh, I know that. My question is, where in the county?
Oh, where?
Yeah.
So it could be anywhere. It could be either in the individual's home. Is that what you're asking?
I'm just trying to
Margaret, I
understand.
think he's asking geographic distribution.
Yeah.
When you look at the increase in number of calls in the year 2020, where would you say the greatest response is needed within the county of Santa Clara? So I would probably venture to say San Jose.
Yes, yes, sorry.
Okay.
Yes, it is in San Jose. San Jose is the most calls come from San Jose.
Okay, but what about for the increases? Is that for the increases or just in general?
In general, and that's also where the increase has been. It's in San Jose.
Mm-hmm. And are you able to talk about what is the nature of those calls? Like in general?
Yes, they're calls that could range from a family member calling because the person is maybe trying to harm themselves. So that could be a situation, or the family member is trying to harm somebody else, or a situation where they have not gotten out of their room for, say, a couple of days. They're not eating, they're not sleeping, there's something else going on. So all types of issues that either the family member or the community person may feel this is not their usual baseline and that there's something else going. In some situations, it might be a new break with mental health issues. In other situations, it could be that the person has mental health, has been diagnosed, and is going through a crisis at that time.
Actually, Margaret, what I was trying to get at was for the increase, do you know generally what the increase has been about, or is it pretty much the same as before, just more?
Oh, it's more, and I did mention it in one of those slides where we talked about as a result of the pandemic, right? So a lot of places are not currently open. And, you know, many places are providing telehealth services. So the community reaches out to the mobile crisis team. The other situation was we did get an increase also as a result of the Black Lives Matter and some of those situations that came up during that time. And some of the conversation we've had today about people not wanting to call the police. And so they're calling the mobile crisis team to come out and help assist rather than calling the police.
Okay, great. Thank you. So I was on an ad hoc committee where we looked at some alternative policing models. And so I got a chance to learn about this earlier. And generally, I kind of support the idea of using, you know, perhaps non-sworn resources or resources that are more appropriate for the incident that's happening. So generally, that seems to make sense to me. But one thing that, maybe this is something that I is a misnomer, but one impression I had was that these programs actually generally cost less than having sworn officers respond to everything. Is that true, or what's your guys' experience or thoughts on that topic?
Yeah, yes, to some extent, it is true. I mean, we haven't done a full analysis to look at the cost of the police versus the cost of mobile crisis team, but we have heard from the police officers and police agencies that it's one less call that they have to worry about, right? And so, so it has reduced the amount of 5150 holds, for instance, that the police has to come out there and write.
Okay, because I was thinking if this costs the same or costs less, wouldn't it be kind of revenue neutral? Like, wouldn't you be able to offset the cost of this program with the cost of, you know, because if let's say on the presumption that this does cost less, wouldn't this be like, wouldn't you actually save money with this program? Because right now it looks like this is going to cost us a lot more. So I guess, how does that kind of mesh up? I mean, it should be about the same, maybe even less, perhaps, right? But why does this program cost so much more?
Are you asking me in terms of the mobile crisis team, or
Yeah,
are you asking?
because overall funding, because it looks like there's a pretty large dollar tag associated with this, right? To make it happen. And so I was just thinking of, because I thought, you know, some of the ideas behind this is you're shifting some funding from sworn officers to non-sworn resources, maybe, you know, psychiatrists or, you know, people who are better able to handle whatever incident, because not all incidents are violent or ones where you need police presence, right? So I was just trying to understand, like, would there be some shifting of funding to have that happens to make this happen, or am I like, maybe you could explain a little bit more, because it all sounded good. Then I saw like the cost involved, right? I thought, wow, okay. It didn't strike me that would cost a lot more. I thought it'd be cost neutral or maybe perhaps even less, but maybe, I don't know if you can get into that a little bit more.
Jen, did you want to explain? I think he's referring to the CMR costs, because that was the only place I remember having seen cost of services or cost of the program in there.
Right, and that's a 5-year, right? That's
Yeah,
a 5-year.
Let me forward that.
Yeah, I think what we showed was a 5-year cost.
I think it's slide 41.
So this particular slide is specific to the service area. So for this one, out of the $24.8 or so million for innovation funding for the 5 years, this is the big chunk, the 17.7 million. And you can see that if we look carefully for each service area, we have about 16 FTEs. And then we also have a training budget. So one of the things that people and our stakeholders had provided during the planning input session was that this continuous training to ensure that folks are culturally competent to serve the service area, always be on the up and up in terms of evidence-based practice, and then also ongoing operating expense related to upkeep of vehicle or additional mobile vehicles that's needed to be deployed to support the program, and general admin overhead. So let's say if we were to add another service site, we would need to tack on and have funding for 1.7.
No, I get all that. I guess my question is, unless I'm not talking about, I'm not talking beyond San Jose and Go. I'm just talking what you have there. But isn't the funding for this offset by? I thought the idea was to use some of the sworn officer funding for this, right? Or is this just in addition? So it's basically adding on to the current public safety effort.
Yes, I mean, we haven't done an analysis of the cost savings, whether, you're talking about cost neutrality.
Yeah, because I guess what I thought was happening was, instead of sending a police officer out to handle a, someone that might be committing suicide or something like that, you're sending out,
Clinicians, right?
Yeah, exactly. Yeah. So I guess, so that would that mean that you would reduce the load on the officers? I mean, isn't that what's happening? Or am I guess what I
perhaps I could take a crack at following up, Councilmember, if you don't mind. So I think in concept, what you're describing, Councilmember Tanaka, is what, quite frankly, folks have referred to as defunding the police and taking resources that would otherwise be used for sworn officers in a non-law enforcement approach. This particular program is funded through this separate state mental health funding source that avoids the financial transaction you're just describing, while it, at least on a pilot basis, will provide the resources to see how well it works and to what extent it actually does reduce resource draw on sworn officers. So perhaps that's a better way to describe it at this point.
I see. Okay, I see. Okay, that makes sense. So then if it does, then perhaps, funding can be shifted. If not, then this would be in conjunction. So do we know how many of the current police calls right now are more like would be serviced by this team versus the current officers right now? So if you look at the total number of calls, how many of the calls would be serviced by this
model?
Yeah.
By this model, yeah. Perhaps Assistant Chief Binder might be the best to describe in terms of a calls for service perspective, what applicability this might have in our Palo Alto area.
Yeah, thanks, City Manager and Councilman Member Tanaka. That's a good question. So we know that if you look at past data, we're responding to probably 50 to 55,000 calls for service. That runs the whole gamut of everything that the PD responds to. Of that, we take somewhere between 5,500 and 6,000 reports are generated, and that's one of our key measures. And we know out of those reports, that we're taking about 4 to 5% are specific to mental health and like a 5150 capacity. So about 4 to 5%. I did the research on the last 5 years. That's what we're looking at.
I see. Okay. So is that the same throughout the county? That just like a 4 to 5% of the calls are would be serviced by this team, this new team that you guys are putting together?
Not sure. We haven't done that research, or maybe Sherry's aware of what other research have gone on.
Yeah, I don't know that we would be able to specify tonight what that specific percentage is, because within the 3 levels of model, we have different responses. But I think that's a great question for us to take back and to analyze.
And actually, if I could, Councilmember Tanaka, I'll just add one more kind of component to this. We know from a police perspective that, oftentimes we may get dispatched to what we call a welfare check, and we know that specifically there's a mental health component to that. But as, the behavioral health services presenters can probably tell you, is that there are a number of different type of police calls or calls that are generated for police response that don't start off as a welfare check. It may be a disturbance. It may be something related to homelessness, and those calls can have a mental health component to them. And what I thought was really interesting, and I bear witness to in their slideshow, was that 80% of those don't result in a 5150 hold. And so we go to a number of calls that probably have a mental health, or we know have a mental health component, but isn't going to result in that 4 to 5% where we take the report or the person on an involuntarily hold. And so that it really is a hard number and percentage to wrap your kind of wrap our hands around.
Okay, no, I can see that. So it may be something that we just need to add, and there's no, I mean, the reason why I'm getting into all this, and I don't know about the other cities in Santa Clara, but I suspect they're probably in similar boat as us, but you know, we were down a lot in terms of our revenue last year, and we're down a lot this year. And, you know, I think, you know, I would look to Ed here, but I don't think there's a lot of money floating around here, but I could be wrong on that. I hope I'm wrong on that, but I don't think so.
I wish you were too, but
yeah. So I'm, you know, and yet, you know, I heard really great things about the Cahoots program. I looked at that a lot. I heard a lot of great things about PERT and, you know, kind of things that this has been able to do. So I generally like the idea, but just, and that's what I was trying to think of. Like, I was first thinking like, what? But this is actually kind of expensive, at least, you know, from my perspective. And then, you know, I was thinking, well, I was hoping there was going to be some sort of offset, but I could see the way this is structured. This is really trying to prove it out that there is going to be some sort of savings, that this model does kind of work. So that makes sense, and especially the state's paying for it, that's even better. But you know, the thing that I just was thinking about, right? And I know Ed and team is putting together our budgets, but I'm just trying to think of like, we were like, because I do think this is a very worthy program, but I was just thinking like, where would the money come from, right? I mean, I don't know, and especially with what we heard from our public safety here, that we might still need them, right? So this may be something that's additive. So it's not like we could cut back our public safety spending, right? It's something where we just have to add on to it. So I just wonder, I mean, even though I'd really like to do this, I wonder if it does make sense just to let the county try it out and see how well it works. And if, you know, if they get really good results, then maybe we could look at, because maybe at that point they understand, well, what percentage can be handled solely by this team, so there's not duplicative effort. How much savings can there be? How do we fund it? You know, what kind of calls are they? It's just really well suited for what's in the outcome, and then, you know, but I don't know whether, I guess it's San Jose or Gilroy. Are they funding this, or who's funding it? No, it's just the state. Okay, actually.
My understanding is for this CMR program, this Cahoots like program that they're formulating, there's about 902.7 that is coming from county, correct? And I think you go before county on the 25th of March, once all the comments have been made and determined, and that's where you're going to get that 902, and then the remainder of that, once county approves of this whole program, is that the team is going to take it and send it up to the state for the remainder of the funds, which is about 24 point something million. Correct me if I'm wrong.
Councilmember Koo, I do want to clarify the 900,000 for the program manager was funded through the Board of Supervisors budget hearing in August. And then we would then request for that 24.8 million to the state once local approval process has been completed sometime in April or May.
So, but this Gilroy, so the two centers you're thinking of having this, Gilroy and San Jose, there's no money coming from those cities directly. It's just coming from the county, right?
Utilizing fully 100% of county funding.
Okay, county and state funding. So I realize a lot of the cases are down south, but it does, and I think my other council members kind of talked a little bit about this. It does make me also wonder, because Gilroy and San Jose are kind of like way south of the county. Why not like just to prove this out, have a little bit more diversity in terms of the location? Why not try to place it further north, like one maybe south and one further north, so that there's you could really see how this program kind of performs countywide versus just having it so centered down in the south? What was the rationale? Because it's if Gilroy and San Jose was, you know, putting up the money for this, I totally get it, right? But they're not, right? So why have it located down in the south versus have, you know, maybe one up here and one down there? What's the idea behind the current location?
So the idea behind the current location was based on stakeholder input. So they were provided data in terms of what the Mcrt, who they're serving, and based on the data that was provided last fall, a lot of concentrated need in San Jose and South County. We shared that data, but we also posed and showed that map of Santa Clara County. If you were to stand up this site, the service site for this new program, what would you like it to be at? A lot of folks said San Jose. They were even really specific around, we want the 95112 area code, or, you know, I'm just throwing out there that they were very specific about even the zip codes in which this new program would surface. As I described with Council Member Stone, this is a community stakeholder process driven. We share information, then we then ask back to the stakeholders, what would you like to do given the information we just shared?
Yeah, I mean, can you bring up the slide 27?
Sure, hold on a sec.
Because I mean, this program is kind of a pilot, right? So we want to, it's trying to prove it that it will work for the entire county. So, you know, if I just look at the map, and not to say that the dots here are representative of the people, but kind of, right? These are the cities in the county. Wouldn't it make sense? Like, so Gilroy is one of them, right? So it's way down south, as about as south as you get, right? And then, you know, there's San Jose, right? Which is kind of in the middle. But if you look at most of the other dots, right, they're kind of on a, you know, top left here, right? So wouldn't it make sense more that you know, because what we want to do is we want to make sure this program works for the entire county, right? Wouldn't it make more sense if, like, the CMR location was like further north somehow, so that you could see it in a more, you know, populated area of the county it works, and maybe a more rural area? So that wouldn't that be a better test of this program versus having them both kind of southbound here? I mean, I'm just thinking about this in terms of if we're trying to prove that this program is going to be legit and will generalize across the county, wouldn't it seem to make more sense to have a little bit diversity in terms of geography versus its current plan?
Councilmember Tanaka, if I might interject a little bit.
Mm-hmm.
Yeah, I think basically from the presentation, my understanding is that it was very much the 30 members of the mental health stakeholder leadership group that made the choices. Mm-hmm. And it wasn't so much the staff members from the behavioral health services that made the choices, because it was a community project based on the instructions or the directives on the funding source. So they opened it to the community. And so it wasn't really the staff. It was actually community members, the 30 stakeholder leadership group. Correct me if I'm wrong, Ms. Morale.
So Councilmember Koo, I'd like to add, yes, it's based on the input provided by the main advisory committee, but we also had those 13 planning input sessions where we heard directly from family members and consumers where they wanted the service sites. In all, we had over 100 folks participate in the process, and we had diverse perspectives. And so as Councilmember Koo just emphasized, this is driven by the community, and that's the basis of the Mental Health Services Act. Now, Councilmember Tanaka, I totally agree with you. Like, if you were to pilot test, it would be great to have diversity. I think if we had all the resources we had, it would be great to have another pilot site. You know, right now, given that we only have, you know, about 24.8 of N funding, our funding source out of innovations is capped. But if there's other funding sources where we could test out a new pilot site, that would be great. But I know that, and like what you've shared here, that sources are limited. So I do You know, this is a very good project to roll out, but I also recognize difficulties in funding given certain resources may be limiting.
Okay, yeah, I'm just looking at the slides here, and I realize it's community members, but I think at the end, is it so did the 30 community members, they had like authority from the Board of Supervisors to mandate this, or was it just advisory, then staff made their final recommendation, or how does that mechanism work?
Yeah, so for this, the Mental Health Service Act, it involves the Stakeholder Leadership Committee, but all our meetings are open to the public and they are able to provide public comment. All the public meetings were also held in partnership with some of our partner organizations. So individuals who may not necessarily attend an SLC meeting will be are open to attending to, let's say, a meeting that's being organized by NAMI or even by the Stanford Psychiatric Wellness Center for our 18 to 25 years old. So, so it's a lot of those folks that actually provided input. We then provided and analyzed the input that were provided at those input meetings and shared with our Stakeholder Leadership Committee. And they analyzed based on the results where people wanted the service site, for example. And I can share with Chantal notes from those planning input sessions so that maybe perhaps you can get a sense and idea about what were the comments provided at those planning input sessions, who attended, who were the target group. So I think that might help.
No, that's great. I was just trying to get a feel like how the decision was made, right? Because a lot of advisory, like, you know, Palo Alto has a lot of advisory boards and commissions, but the final decision is largely made by City Council. So I was wondering if that's the kind of structure, or actually those 30 people actually had the final vote.
No, they don't.
They don't. Okay, that's what I thought. So who had the final vote, or who makes the final decision?
So it goes up to the Board of Supervisors.
The Board of Supervisors do. Okay, that makes sense. Okay.
Councilmember Tanaka, if I might also suggest that the one other program that we in Palo Alto are directly participating in with the county is the PERT program. So at the appropriate time, it might be useful to review the status of that. I know that the county has been working through staffing in order to be able to identify staff, because that is a near-term allocation of resources here in Palo Alto.
And just for you, so right now there's no city resources or funding being put on this program yet at this very moment.
In terms of the PERT program, or the
no, sorry, the one we're talking about tonight. Sorry.
Oh, correct. Well, actually, we're talking about all of them, but that said, for the CMR, thank you. CMR means something different in Palo Alto, so we are not putting resources into it.
Okay, great. Thank you. And so the motion, can someone bring up the motion again, just to make sure I understand this? The motion that's on the floor.
So Jan, if you can stop doing screen share.
Right.
Okay.
Councilmember Tanaka, I looked up a question you were kind of asking earlier about cost savings for at least as Eugene, for example, for their Cahoots program. They save on average 8.5 million a year from the program.
Yeah, that's what I remember. It was actually quite, so that's why I thought, wow, this is great. You know, we provide better service and we save money. So, I mean, how can you beat that? So that's why I was looking at it, go, wow, this is actually a lot of money. There's no savings, but I understand what's going on, which is they're just piloting it, and we'll see if there's any savings, if at all. But thank you for researching that.
No problem.
Yeah. So that was also my impression. It's also like these programs, like they actually saved money. So I was like, wow, like what happened here? Okay, good. But on this motion then, just to be clear, so there's no commitment of dollars here, right? It's just exploratory. And then we'll see, like, how things look, and then we'll decide, right? So there's no commitment on our side with this motion at this point in time. I mean, should we expand the motion a bit? I mean, I don't know. I think Councilmember Stone also had the same feeling, but should we not push for maybe, and of course the Board of Supervisors makes the final decision, but should we not push for like a CMR location to be more like in a central populated area versus, like where more of the dots are of the cities versus like kind of skewed toward the south? I mean, would that not make sense? I don't know, look at the maker for.
I'm fine with that. I mean, I don't think it would hurt us asking and advocating for that. It doesn't seem, based on the responses we've gotten, that it would help. But hey, I'm always a believer. You might as well ask, and all they can say is no. So
Yeah, well, that's what I was thinking too. So yeah, so if you're amenable to that, that'd be awesome.
So
if the seconder is.
If I might just understand, so what right now, what we're expressing to both the behavioral mental health department here, represented by the 3 members, that we do have an interest in participating should that funding become available, or should they start considering other cities. So what we're, and then to communicate it to the supervisors. But we want it here, right, in Palo Alto. Councilmember Stone, is that, or is it okay to be in a more central location like Sunnyvale, or, I mean,
Yeah, I mean, I think all of our preference would be to have it in Palo Alto, but I don't, you know, if that advocacy of the best we can do is get it to Mountain View or Sunnyvale, I would say that's close. That's probably close enough.
Yeah, I still think that's a win, right? If that happens.
And then it will be closer to North, I mean, within North County area.
Yeah.
Is that what you, okay. I'm fine with that.
Yeah. So I think that would be great. That way I think it would be better for the program overall, because that way there's better geographical diversity in terms of how this could work. And that way, you know, if this gets rolled out countywide, right, there's more evidence and proof that could work in different environments. Should we say central location, or should we say more northern location? Would that be a better way of saying it?
Yeah, that's what I was gonna ask for that to be changed, because I think central location is San Jose.
Well, geographically, but not center of all the cities. The center of all the cities, if you go back to the map, is maybe more like Sunnyvale or something like that.
Yeah,
Let's keep it to a more northern location.
Yeah,
northern location.
Yeah. Okay.
Okay, great, awesome, thank you.
You know, I have a question. So earlier somebody said about, I forget, it might be a member of the public that said it's paid by Medicare. Is that, how does the patient have to pay anything when they're responded to?
No, I mean, no, we're not billing per se, and I think that's the other part of that revenue question that was coming up at one point. So we only bill if the person has Medi-Cal, but it's not contingent on the insurance for us to serve anyone.
So that won't be so much of a barrier either for calling.
No.
Okay, that's good. Okay, well, are we ready to vote?
All right, just to clarify the motion, I think it'd be better to, because right now I think it's still a little ambiguous. Maybe we can add language to express interest in participating in Santa Clara County's new community mobile response program. And at least the acronym that the report uses is CMR. Thank you. Is that fine, Chair Koo?
Yeah, it's actually CMRP.
Oh, okay. Sorry.
Yeah.
The staff report said CMR.
I'm sorry. It's I think Janet's CMR, and I put the P just because
Oh,
program
you
is
did.
after,
Okay.
but you guys refer to it as CMR only, right, Jan?
Okay.
Yes, we typically use CMR, but I've seen other folks say CMRP. So we can consider both, but I think spelling it out like that, you should be clear about your ask.
Okay, thank you. Anything else?
Looks good to me.
Okay, so let's vote. Councilmember Stone,
Yes.
Councilmember Tanaka,
Yes.
I vote yes. And it passes. So I just want to say thank you so much to Ms. Obilar and Ms. Morale and Ms. Terrell for being here for so long and, you know, just helping us understand the program. It's very exciting to see this coming together, especially the last one, which also involves the community. I know the mobile CRT is also very exciting too, but you know, having that community component is extra special. So thank you for being here tonight, and we hope that we'll be more interactive moving forward. Thank you.
Thank you.
Thank you.
Thank you.
Have a good evening.
Thank
Have a good
Bye.
evening.
Thank you.
Okay, thank you so much for organizing that. It's really great to kind of have an idea that this is actually moving forward and what county is doing as well. With that, we'll move into the next item, which is an informational update summary of recent race and equity work since November, including update on records management system, contract for police data collection.
Awesome. Thank you, Chantel Cotton Gaines, Deputy City Manager. So if there were a full informational report style for policy and services, this would have been that. So since there's not officially an informational report, we did have it on the agenda, but I just wanted to use it as an opportunity to let the committee know where things are with the race and equity efforts, and being cognizant of the time, I will quickly run through it. I think the biggest part to emphasize is a lot of work has happened since the council motion in November. So that's kind of the high level. I'll highlight a couple of things we have done. A lot of community engagement in the early part of this year. The 21-day racial equity challenge is a partnership we've recently done with the school district. We had over 2,000 participants in that challenge community-wide, and heard really great things. A lot of opportunity for people to have dialogue both online and through Thursday Night Live. So that was really great. We had the Martin Luther King Jr. event with YCS and a youth panel there. And the students are just so passionate about this topic. And it's really great to hear their voices and to hear the ideas that they have amplified, working with Mr. Reverend Coloma Smith with the HRC as well. We posted a blog in January just highlighting some of the efforts to date and some coming. So we emphasize things going on with the Art Center with an exhibit that they have, as well as we're doing a book to action event in May, I believe. And that'll be focused on Ibram Kendi's book, How to Be an Anti-Racist. So the pieces I'm going over right now are really focused on some of the community conversations that have happened and will happen. And then in terms of the list of recommendations, the last one as well was Ruby Bridges Walk and Roll Month through Black History Month last month in February, encouraging people to get up and move, which is our Safe Routes to School big piece of it as a push. But in addition to that, it was really focused on Ruby Bridges, who was key in the first integrated school. So then going into the 16, I believe number 16 recommendations from City Council in November, I'm going to breeze through these. So please excuse me in advance if it's really fast. The first is adopting a mission statement. That was done in November. Thumbs up to council. You guys did yours first. Second is looking at the records management system. So we are working on that. We had the contract approved in November, and we recently had the servers installed. So we're moving forward on that. And this is just an opportunity at these policy and services check-ins to let you know that that's still going. Once it's installed, then we'll be updating you on the actual contact data. So C is related to that as well. Focusing on the PERT program, Mcrt, and their new program, that was item D. We just had an amazing discussion on that. Directing staff to develop a policy on the timing of records release related to investigation. So we continue to work on that policy, but all incidents to date meeting the disclosure criteria have been released. Directing staff to amend the IPA contract. There are a few items on here related to that, and we are in discussions with the police auditor on that contract amendment. So I'm just kind of leaving that high level for all of those. adding the use of force information to the regular supplemental report. So all the use of force information was reported. That was from July 1st, 2015 through June 1st, 2020, and it's available in one of the data transmittals from last year during the ad hoc work. The next use of force report will be included in the supplemental report in January of 2022. Referring the police reform legislative priority, we did that in December, and it has been included in the legislative guidelines adopted by council earlier this year. Referring all race and equity works of policy and services, that has been completed. That's what we're doing now. And looking at the negotiations with the Peace Officers Association, we'll bring this in the fall of this year prior to negotiations beginning. So there's still time for that. Letter L, directing staff in coordination with the county or the city's overall diversity and inclusion efforts to do a demographic assessment as a baseline of staff. Staff has begun this analysis. We are in process of looking at the data and working on that. Developing related to the CDAW recommendation, putting together a summit on gender equity. We had an update on that at the last Policy and Services Committee as well. Staff has been in contact with Chair Koo, as well as there's a team of us at the staff level working on this and organizing many of the details, and we have an estimated time frame for it. So we'll continue to work forward on that equity or gender equity summit. The next one, item N, assigning a resource, thinking about cahoots. We have a conversation today about that, so you can move past that one pretty fast. Amending the contract for the IPA, we are in discussions. And the last two recommendations, referring a conversation to Policy and Services Committee about the independent police auditor oversight of internal complaints. So we will be working with Chair Koo to schedule that to Policy and Services, as that was a referral from the full council. And lastly, directing staff to work with IT to streamline publishing the police policy updates on the city website on a quarterly basis. The police department did a lot of creative thinking on this, and they have a streamlined redaction process to get this done a little bit faster than before. And the policy was last updated for February 1st for this quarter. So we are up to date on that. The rest of the report that you all will see is just giving a little more granular information about our plans for the IPA contract amendment. So with that, I'll take any questions, but just wanted to breeze over all of those updates. And as you can see, there's a lot of moving parts, and we are happy.
Okay, and at this time, we'll go to the public for any questions or comments. Ms. Baum, would you help me?
If there are any members of the public that would like to speak on this item, please raise your hand at this time. Chair Koo, it looks like we have one public speaker so far. Winter Dellenbach, go ahead.
Okay, several things really quick. First of all, in looking at the packet, these things that were just zipped through in the packet are called recommendation text, and I don't know why they're called recommendations. These are motions that were made, discussed, and passed by the City Council on November 16th. I don't see anything recommendation about them. And they are, most of them are direct staff to do certain things. I wanted to talk about F and G. In F, the city states that amended independent auditor contract is anticipated to be signed before the council summer break in June. I want to say to you council members, it's imperative that this be done, because if it's later in June, it will postpone a number of vital council initiatives for months. So it has to get signed by your summer break in June. I wish it weren't taking that long, but it has to get done by the time you go on summer break. And also, the expanded use of force oversight that you passed applies to canines, applies to police dogs. In June of 2020, Palo Alto police dog was involved in a use of force incident. You'll be meeting on that in closed session on Monday. I ask that you insist that this incident be specifically included in the IPA's purview, even though it took place in 2020, his contract isn't going to be signed till 2021. Surely you can get that specific incident included, because if it's not, he won't have oversight in it unless the police department decides to conduct an internal investigation. That would then trigger his jurisdiction over it. But you don't have any control over that. So make sure one way or another, it gets included in his oversight. G, in the list of your motions that you passed. City Council voted to direct staff to include a use of force information as a cover memorandum to each IPA report. The IPA reports twice a year to council. Therefore, it seems clear that the use of force information memorandum, which is a new thing, is to be reported twice a year, not just once a year, as in G, that the staff wants to do it once a year. It should be done twice a year. And it doesn't matter that it's just half a year. In the use of force report that's indicated that you can go to look at, it's 5.5 years worth of reports. So they've reported out a half year before, they can report out a half year now, because it's what's in the report, not that it spans half a year, that's important. It's the information that the public has and that council has. One more thing, give me one more second. And I'll leave it at that. I can do more. Thank you.
Thank you, Ms.
Oh,
Dallenbach.
you gotta talk so fast.
Thank you.
I'm exhausted.
Okay, any question? We'll go back to council, to committee. Any questions, Councilmember Tanaka or Stone? Guess I should look for hands.
I went first last time, so I'm happy to go last this time.
Councilmember Tanaka?
You know, the one thing I just wanted to ask about is, and it's kind of in this umbrella. So I'm hoping that we could talk a little bit about it. Is I'm not sure if you've been watching the news, but there's been some like anti-Asian stuff been going on. I think you guys saw in San Francisco a 84-year-old grandfather was killed, right? And you've probably seen some of the anti-Asian violence. Has staff been thinking about this at all, or what's your guys' current thoughts around this kind of anti-Asian sentiment that's happening?
Let's see. Well, certainly has been a topic of both top of mind as well as some discussion, but nothing formal at a staff level. I think as it relates here to our recent equity work, quite frankly, these have been policies addressing our own operations, not so much what might be perhaps among other communities, more of a kind of a statement of support and mutual concern across racial lines. So it really hasn't been a part of this report, but certainly if the council is interested in taking steps along those lines, that I have heard other communities maybe passing resolutions of solidarity or things like that.
Has there been much of that going on here? Do you guys know? I mean, from the police reports?
In terms of actual violence, perhaps Assistant Chief Binder could respond on that.
We're not seeing anything specific. I mean, we do have Asian members within our community that are victims of crime, just like anyone else or any other race or nationality. And whether those are specifically tied or committed because of a person's race, we don't have any specific cases to point to at this point. We are aware of the stories and the news reports that are going out. It is something that we're keeping track of, but nothing that I could report here of substance at this point.
Well, that's good. I just see the reports of like elderly Asian people getting beaten up or killed, and it doesn't seem right to me. So I just wanted to make sure that's not happening here. So if it's not happening here, that's a good thing. But do you guys even track it, or is it just not happening. I'm hoping it's just not happening, but I don't know.
Well, like I said, the police department is very aware of what's happening across the country and these types of targeted incidences. And I can tell you that I'm not aware of any specific incidents where we had where someone's been targeted in that fashion.
Okay, great. Thank you.
And if I can add on to just a quick point as well, the community conversations around just these topics of race and ethnicity in general, that's part of why it's just continuing to bring that awareness that we have differences and that there are opportunities for us to continue learning together. So there were a lot of local resources as well, even within the 21-day equity challenge, which is intended to help people continue to think beyond just their own personal life experience.
Councilmember Stone.
Thank you. So under the recommendation letter F, the IPA's scope of service includes incidents that involve the use of some form of weapon or requiring the subject to experience injuries that necessitate any treatment beyond minor medical treatment in the field. Would it make sense to add language that doesn't involve a weapon, but does involve excessive use of force that goes beyond what is reasonably necessary to subdue a suspect? Because I'm worried that if the IPA scope is limited to that we could be limiting quite a lot of poor behavior, but that just doesn't get elevated to that pretty specific definition.
I can actually answer that for you, council member. I think there's a differentiation between legal and within policy use of force, and that's what we were trying to cover with what we sent to the IPA. If we did have a force incident that the department or was deemed excessive, that's going to fall into another category. That's going to fall into like a internal administrative investigation. And then if that involves a community member, that is another trigger for going to the IPA, and that is something that the IPA is going to look at.
But it has to get through the internal process before it gets to the IPA.
Yeah, I mean, that's the same as even the use of force incidents that you're looking at that are listed there. What the department does is, if I can kind of create a timeline, the incident occurs, the department looks into it, whether it's via supervisor report on use of force or an administrative investigation, an IA. And then once that investigation is completed, then that is sent to the IPA for review. And that's what you'll see in those IPA reports. I will say that one of the things that the department does is we do take a proactive approach with the IPA, in the sense that when we have cases come out, we generally will give them a call and give them the heads up, because oftentimes they'll get contacted independent of the police department or council by community members or people who may have seen a headline, and they'll get asked. And so by having a conversation with them about ongoing cases, either internal affairs or use of force cases that are going to end up with them, it kind of gives them just enough information to answer questions and be prepared when they get reached out to. And then ultimately, once we've come to a determination or a finding, that's when the case goes to them.
And is there a part of that process where within the internal investigation that the department chooses they do not want to send this to the IPA for that kind of specific area I'm talking about? Does that mean that it could be precluded from going to the IPA?
I'm not sure I understand your question, but if you're talking about excessive force cases, I think that's a whole different, in my opinion, that's a whole different ballgame than lawful legal force that's used within policy that the IPA is going to look at. It's a whole different avenue, because when you have excessive force, not only could that be deemed out of policy and could result in employee discipline, but there's a potentiality for criminal implications for excessive force. So those things, things are, the department doesn't have the discretion or the leeway, because there's that citizen component. If a citizen's involved in that force, that the IPA is going to get it.
So Chief, I think what the council member is asking is, does the IPA receive all IA investigations, regardless of whether they're founded or unfounded? And, does the department have discretion to say, oh, we don't want to send a particular investigation to the IPA?
Okay, yeah, I apologize. Yes, other than obviously the employee investigations that are sent to HR. So if it's if there is a citizen component and the department does an administrative investigation resulting in an internal affairs investigation, regardless of the finding, even if the department finds that the officer's conduct was exonerated, meaning that what they did was correct or unfounded didn't occur, that's still, no matter what the finding is, they all go down to the IPA. And that's part of the IPA's job, to determine whether the investigation was fair and balanced, and the conclusions that the department drawn, were appropriate.
So it seems like there's already kind of a process for this. It seems like if that is the case, I would be more comfortable, and I think the community would be as well, kind of enumerating that within the kind of explicit scope of the IPA's services here, because I do think that's an important area. And I understand that if it does reach to a level of excessive force, right, it becomes criminal, but the threshold, if I'm remembering correctly, for excessive force does require a significant injury to the victim, and that is not kind of what that's already included within the scope. So I'm definitely more looking at behavior that doesn't involve a weapon of any type and doesn't actually ultimately end up with an excessive injury. That's still going to be covered in this report, because I think we've seen incidents of that, maybe not in Palo Alto, but elsewhere. I don't. And that's not to say it hasn't happened in Palo Alto, but where we've seen kind of excessive force used, but the victim is fortunate enough not to sustain significant serious injuries, whatever the legal definition is for it, that I think would be helpful to be able to have within the scope of the IPA. And I don't know if staff has any thoughts on that.
Yeah, I think that was a lot of what the talk was last fall with our race and equity and the department revising its force policy. I do feel that the direction that council gave back in November was very comprehensive. Our thought from the PD is, number one is we want to be transparent, and we use force very little. In the circumstances that we do use force, we don't have a problem sending it down there. I think what we were trying to maybe make a differentiation from was ensuring that the IPA is spending their time looking at important cases and cases that involved force that could cause concern in the community. So for instance, we may use, if you're familiar with our force policy and what triggers a supervisory report on use of force, a complaint of pain without any visual injury will kick something like that off. Is that something that the IPA needs to see? We kind of debated that back and forth, and that's why we ultimately decided on the direction that council gave back in November.
If I could also just note that, as indicated in this status report, this contract will be coming back for council review in the next few months. So you'll really have an opportunity to dive into exactly what it says and council's confirmation that it's consistent with your intent.
Okay, that's helpful. Thank you. And I think, this is a very small excerpt within this staff report. So I'd like, it would be nice to be able to see the language a little more, read it more thoroughly. And then I just have two other questions. Where are we with the 8 can't wait reforms? Have all of them been implemented? And the opportunities to be able to kind of strengthen those that have been implemented, but maybe need some tweaking.
So as part of going back to the summer, as part of our conversations, the conversations I had with HRC and Chair Smith, and then following up with council, there was pretty extensive, robust conversations about our force policy. If you recall, many of you were part of that. We went through the 8 can't wait one by one. with HRC's recommendations to council. We went through those individually, and ultimately the force, our force policy was revised to include that input and direction from HRC and council, also consistent with the legislative changes that had came about over 2019, or that were going to be in effect in 2020. And so we coupled that all together, and that's done. And that's been, we launched that probably within the week, if not the day or two after council gave that direction in November. That does include the expanded language on de-escalation. We reformatted our force reports to specifically include boxes to discuss de-escalation. All of this stuff we've also gone through with the IPA. They're very familiar with it. You'll actually see some verbiage about it in their upcoming report.
Councilmember Stone, you need to unmute.
Thank you. Last question, because I feel like it's related, and I know this is a new thing. Where are we at with police radio encryption, and are we working on that? I mean, I'm sure we are, but an update would be helpful.
Yeah, in fact, the council will get that update as a part of your April 5th agenda. We've got a study session scheduled with the police chief to report on that, as well as other issues really for the calendar year. And I was wondering, and actually I should know the answer to this, Assistant Chief Bender, in that report, will we also be talking about any use of force statistics or other elements that might relate to our earlier discussions as well?
Ed, are you talking about the year-end report that Chief Johnson did? Yeah, there should be. We have looked at our use of forces from 2020. We've broken them down, and that should be part of the conversation.
Good. So I think it'll hit a number of areas, Councilmember Stone, of policing, and be a good opportunity for the council to review overall with kind of a bird's eye view, including the radio encryption issue.
Perfect. Thank you. That's all the questions I have.
Thank you. I wanted to ask Assembly Member Bonta, I think last year or the year before had I think AB 1550, which was about a community making calls, emergency calls, that might be about that, it's one of those calls that's like the Karen calls. Did that ever go through? Is that being reintroduced again? Do you happen to know?
I do not. Would either Andrew or Chantal be aware?
I just attended a legislative updated training session last week. I didn't hear anything about that. That hasn't come up to my knowledge.
And do we, at this point, within our own police, have anything in our police code that would prohibit calls from having police go out to respond to a call that is going to be about that has to do with discrimination or racism?
Again, not that I'm aware of. Please, Assistant Chief, go ahead.
I'm not sure. I think I agree with you, but I'm not sure if I totally understand the question. Maybe re-ask.
I was just, so, I just wanted to find out if perhaps now within our police code, there is already language in there or a rule that addresses if somebody calls and it's about, and when an officer goes out and finds out it actually is a racism call. I mean, it's a call that is discriminating against somebody. And is there any repercussions or to the community owner, a community member who called on it, who called in that incident that is
So
actually not an incident?
Chair Koo, are you talking about maybe someone calls on someone within the community, and we determine through the course of a response and investigation that that caller was calling due to a racially motivated factor or something to that case? I mean, that could be, I mean, depending on the circumstances, you know, that could be something that could be like a hate crime or a hate incident or something to that effect. It really just depends on what their intent is for calling, why they called, and what the details of the event were.
But would there be a if it's determined that it is just a frivolous call, or you know, called just because they don't like the, you know, due to color or whatnot, is there any kind of ramifications or penalties?
Like a recourse, maybe?
Yeah.
So I couldn't tell you off the top of my head whether there's a specific law. I mean, it could be something, again, depending on the totality of the circumstances. It could be a case that we investigate and write up and send to the district attorney's office for review. I mean, there are a couple potential actions we could take.
I see. Okay.
I think what's important too is that, and one of the things that our dispatch, our 911 communications center does really well, is they ask the right questions. And, you know, our officers shouldn't be put in a position where they're responding to a call for service that's based just on someone's race or a component of someone's race. Remember, we're law enforcement. And so there needs to be something more to it than this person is X race in public. We're not going to go to that. We don't have an interest to go to that. And so that usually stops, or should stop, right at the call center, where the dispatcher asks the right questions, makes the appropriate determination that there's not a need for police service, because we know that this is a free society and you can be whatever color you want and be out there in public. We're not interested in sending a police response unless there's a criminal component or a police need, a public safety need for us to respond to.
So it's good to hear that dispatch at the call center does have that already in place with their questions to determine whether it is a frivolous call. Thank you for that. Okay, well, you know, with the talk, with us doing this, it's also not just only on police to do the right thing. It's also within the community that they need to realize that there's a part of it that is brought forward by themselves. And like you said, it's just not right to put the police in that position to have to respond to something that is due to color of skin or whatnot. But okay, well, so this is informational. And I think you do return with the IPA oversight of internal complaints regarding misconduct related to harassment, discrimination, or retaliation that results in city investigation of uniformed officers in April, right?
Let me check the pending list. I believe that's for April, but let me double check. Sorry, I'm really slow. It's late.
No worries. No worries. You know, while you're looking, I just thought of something else. For the 21-day challenge, so now that it's completed, it's moved to the next project, right? So what is being done in order to follow up on all the things that was learned from those 21 days?
Good question. So it can go in a lot of different ways, I think, is the short answer.
Oh, I didn't know you were going to answer. You're looking for
sorry.
it. I'm sorry.
I found it, so it's fine. I'll just keep talking through both. But I think you're hitting at the point of just the community dialogue on this topic, which links back to your last point about encouraging the community to see the ways that all these things are interconnected in terms of maybe calling the police because someone doesn't look like they belong, quote unquote. And I think that links to the HRC's discussion as well, which is the underlying theme that they pointed out was that as much as we want to think that everybody feels that everyone's the same in our community, we do realize some people still feel they don't belong. And that sense of belonging was the key. So I think part of what our thinking is the HRC's work of the 100 influencers and those smaller community dialogues is one of the ways that we continue the conversation. Another is the book to action work in May, which is through the library. And we'll have some smaller events that are connected to that and an author discussion as well. So really, the way we were thinking about it with the district is continuing the conversation, I think is the short answer of that. Ed, did you want to offer anything before I answer the calendar?
No, I think that hits it right on, as well as, we've got our own organizational follow-up actions, and the 21-day challenge have certainly spurred additional conversations for ourselves as to opportunities for the city to continue and make progress in other areas.
Yes, and we've also been thinking a lot about the boards and commissions work and their interaction with the topic of our race and equity work. So that's still growing as well.
Okay.
Was just linked to it.
I just thought, the program 21 days is certainly, it was, a lot of history, a lot of education, conversations and so forth. And so where does it go now? It would just be a shame to drop it, to kind of, so I see that it does spur into other programs and other education, but certainly that whole component shouldn't just go away. It should continue to.
I'm sorry, I should have also added that we are also looking to use the same resources for other programs, and including taking perhaps selected pieces of the 21 days and do mini programs. And I know the police department has also been looking at using it as a component of continuing education. So the resources put together for that program are tremendous, and so really valuable for us. And we hope we can both retain access to it as well as continue to build on it over time.
Super. Okay,
and
thank
the
you.
Website the resources will be up on that website, PA Equity Challenge, through the end of this year. And the district will continue to monitor it through June. So we're curating it, so we kind of save it and have it, but also people can easily just go to the website in the meantime. To your question about the IPA referral, yes, we have it listed for April. I know we just continued the protocols and procedures discussion as well to April. So offline, Chair Koo, we can balance this out because we also have a few other items listed for as tentative for April, and it's looking very full.
Yeah, I couldn't decide which one, but okay. So if there's no more comments or questions, going once, going twice. And I think it's an informational item, so there's no action needed. Thank you so much. Now I have to find my agenda. Oh, it's here. Future meetings and agendas. Funny, we're talking about that. I think so. April, we have the audit, quarterly audit. We have a legislative update, the IPA item that we mentioned, and we continue the protocols and procedures to then, but then we also have town hall planning. So either we start early or we have to defer some things. So maybe I'll chat with you, Ms. Gaines.
That sounds great.
Okay. Unless you have any preferences, colleagues?
I'm fine starting earlier.
I'd rather we just, because I think a lot of times we don't have full agendas for policies and services. So I'd just rather have more regular meetings. So unless it's urgent, we could just maybe push out the meeting. And then that way we have kind of more of a steady workload instead of trying to stress staff out too much on just one particular day.
Yeah, okay. Thank you for that comment. I think we're gonna, there's some things on this calendar on April that is actually pretty important to address. But okay, so I'll chat with Ms. Gaines offline. But if there's nothing else, nope, then I'm gonna call for adjournment. Have a good evening. Thank you again for everybody.
Thank you. Good night.
Good night.
Night.